All right, let's resume our session. We'll continue with Dr. Victor Bernet. Dr. Bernet is the chair of the Division of Endocrinology at the Mayo Clinic in Jacksonville, Florida, and is an associate professor for Mayo Clinic College of Medicine. Dr. Bernet received his medical degree from University of Virginia School of Medicine and completed his internal medicine residency at Tripler Army Medical Center, followed by fellowship in endocrinology at Walter Reed Army Medical Center. He has been an ABIM certified endocrinology, diabetes, and metabolism since 1995. Dr. Bernet served 21 years in the U.S. Army Medical Corps, retiring with the rank of colonel. Dr. Bernet's main academic interests are thyroid nodules and thyroid cancer. He has been a co-author of more than 50 peer-reviewed articles and 15 book chapters. Dr. Bernet is currently serving as president of the American Thyroid Association. He is also an active member of ACE and the International Thyroid Oncology Group. Dr. Bernet also serves as a representative for Mayo Clinic on the NCCN guidelines. Dr. Bernet, happy to have you. Dr. Bernet is going to talk about postoperative radioactive iodine imaging and treatment. This would feel better after we completed our journey in the dark matter of nucleus and the dark corners of history. Vic?
Thank you for that introduction, Seiza, and I appreciate the invitation to speak at this terrific conference. I noted we have attendees from 19 different countries, and I would mention while Seiza and I live in the same state of Florida, that South Florida and Northeast Florida are worlds apart in some respects. So as Seiza mentioned, I was asked to talk about postoperative radioactive iodine imaging and treatment. So when we think of diagnostic whole body radioactive iodine scanning, I think we can agree that there's an intent of identifying and localizing metastatic disease, whether it be regional or distant, that we haven't already discovered with the testing and surgery and stuff that we've done prior to this point in time. The diagnostic whole body scan can also guide radioactive iodine therapy. It can help us decide whether we should use radioiodine or not. We can think about preparation, whether we want to do recombinant human TSH or thyroid hormone withdrawal for treatment, and also maybe select a radioactive iodine dose as well. Diagnostic radioiodine imaging, as far as initial staging, is really obtained to get actionable information that alters the management decisions beyond the information we already have. So we integrate preoperative clinical data and surgical pathology, and then we have the idea that diagnostic radioactive iodine imaging, if we're going to use it, should have an impact on improving outcomes, both disease-free survival and overall survival.
We don't see your presentation.
Oh, I'm sorry.
Just share your screen or share your presentation.
So please. I'm sorry. Thought I had done that.
That happened to me yesterday.
Yeah. All right, let's try that again. All right. I was trying to avoid the same thing that happened to Doug, and then I did something else. Here we go. All right, and then I'm going to switch this around. Now, can you see it?
Yes.
Okay, sorry. So again, identifying and localizing metastatic disease, both regional and distant, and helping decide whether radioactive iodine therapy we are going to use or dose selection. And then we'll skip here. We were talking about, and I'm sorry, the home phone never rings, and it decides to ring right this moment. So that's just priceless. But if you can hear that in the background, I apologize. Low iodine diet preparation is, of course, important, and to have an appropriate restricted amount of iodine. I actually have to say I'm still surprised that I run across patients that I'm seeing in consultation that previously don't seem to have been put on a low iodine diet. So I would say that's definitely very important, because you could have false negatives if you don't do that diet appropriately. Of course, there's TSH stimulation is imperative, and again, you have options of thyroid hormone withdrawal or recombinant human TSH. As has been prior mentioned by several of our nuclear medicine colleagues, specific isotope of radioactive ion used actually has implications. I-123 is a gamma emitter, improved imaging qualities. There's no stunning concern, has a shorter half-life, although a little bit more expensive. While beta is not necessarily, I-131 is beta and gamma, not necessarily optimal for imaging. And there's a concern potentially for stunning with increasing doses. And as you decrease a dose, maybe decrease sensitivity. We've also alluded to that the imaging technique can make a difference. There's planar and SPECT-CT. SPECT-CT seems to give an improved spatial resolution and anatomic resolution. And also planar is maybe not too less sensitive, but again, not as good with spatial resolution. And then, of course, there's the administered dose that you are using to treat with or scan with. I think when we talk about this, it's good to take a step back and think about survival and realize that looking at the SEER database, that a good proportion of our patients have localized disease confined to the primary site or maybe regional lymph nodes. And then when one looks at survival, whether it's 5, 10-year or long-term, these patients tend to do extremely well. So we need to keep that in the back of our mind if we're really going to improve their outcomes with radioactive iodine treatment and ergo using scanning to decide on radioactive iodine treatment. When we look at diagnostic radioactive imaging postoperatively, I would like to concentrate on intermediate risk thyroid cancer. And the reason for this is I think there's good data to show that low risk patients by and large don't really have a survival benefit associated with radioactive iodine. And I think there's also some agreement that high-risk thyroid cancer patients potentially are going to benefit by iodine scanning and whole body treatment. So really, I think the debate is in the group of the intermediate disease. And I think this is because this is a very heterogeneous type group. You can see recurrence rates vary between 5 to 30%. And that's a big difference. And I think that's because not all intermediate disease, patients with intermediate disease are the same. And of course, the idea is that the radioactive iodine scanning will find RA, avid, occult metastases, which would lead to more accurate risk stratification and also inform long-term management planning. This graph, I think you become very familiar with, that multiple speakers have used this, and I've again highlighted intermediate risk. And I think the reason to look at this is we see a jump up, and it is a continuum, but when we see this line, we have like 5% recurrence. Now we're getting into 10, 20% recurrence once we have significantly pertinent clinical lymph nodes, PTC with vascular invasion, BRAF mutation, and maybe extrathyroidal extension when there's BRAF mutation present. Again, Mike mentioned that with the AGC8 version, we don't really use just minor extrathyroidal extension. So these are the kind of patients that we're talking about. There's a debate what the benefit is of the iodine scanning and therapy. Of course, I think the audience is familiar that there are a couple different ways we can do radioiodine imaging. One, we can, of course, prep people with low iodine diets and then either get them ready with recombinant human TSH or thyroid hormone withdrawal. And then one can do this and then treat with radioactive iodine and then do a post-therapy scan, versus one can do a pre-therapy scan and with that data decide to treat and then do post-therapy scanning thereafter. And this is just some regimens that potentially using, and we've gone to a route where we can do the treatment, scanning and treatment in 1 week with 3 doses of recombinant human TSH. And I'd say we do a lot of patients with recombinant human TSH over thyroid hormone withdrawal, unless they have distant metastases or very severe disease, and we'll consider doing with thyroid hormone withdrawal. When you look at pre-treatment radioactive iodine imaging, I've learned from my nuclear medicine colleagues about the principles and the word theranostics. And so in this context, we think of, well, we potentially can have a patient go from M0 to M1 by finding a metastatic disease. There's also going N0 to N1. And of course, it must be acknowledged that distinguishing foci of residual thyroid versus actual nodal metastases in the thyroid bed can sometimes be challenging, even with the best of technology. And note that sometimes that will not change the risk category of the patient. Also, of course, finding pulmonary metastases that might have been missed by chest X-ray or less likely CT is something that can potentially happen with iodine imaging. When we go look at the last ATA guidelines and their comments in regards to postoperative disease status and decision for using radioactive iodine imaging and treatment, well, one is assessment of the postoperative disease status and whether additional treatments such as additional surgery, radio or iodine or other treatments may be needed. Comment on postoperative TG testing, either basal or stimulated, noting the nadir after surgery is about 3 to 4 weeks post-op, but really that we don't have a good optimal cutoff to say what stimulated or basal TG would really make us proceed with radioactive iodine administration. Of course, there's severe elevations which would stimulate our interest and concern, but there are a lot of patients that there's variable TG, some of this having to do with potentially the surgical technique that was used. And then their comment, or the comment of the ATA committee that wrote these guidelines, was postoperative diagnostic whole body scan may be useful when the extent of the thyroid remnant or residual disease cannot accurately be ascertained from surgical report, neck ultrasound, and when the results may alter the decision to treat or the amount of activity to be used. Now, Mike Tuttle and some people have referred to the Martinique group or the multilateral group, which consists of endocrinologists and nuclear medicine specialists, both from the United States and Europe, that have gotten together and then trying to work through some of these issues. And one of the first things we did when we met, we came up with some 10 unifying principles and such, and 2 I will highlight here that are relevant to this talk. Postoperative disease status evaluation should be standardized and integrated into routine clinical care. And optimal patient selection for I-131 adjuvant therapy requires consideration and evaluation of multiple factors beyond postoperative disease status and risk stratification. What are some things that we can do as far as tools for postoperative assessment? Of course, we have the pathology report, and we can use the AJCC 8th edition and other tumor calculators to determine risk. We have neck ultrasound that may have been done preoperatively and also can be done postoperatively. Of course, our TG panel, whether it's stimulated or unstimulated, radioiodine scanning, as we've mentioned, chest X-ray, and then 3D anatomical imaging of the neck and chest, or potentially sometimes even the abdomen or the pelvis, PET CT and FDG, and for those that have I-124 available. When we think about important factors that assess this, impact this assessment, there's one: quality of the pre-thyroidectomy lymph node mapping. And if you miss lymph nodes by ultrasound, yes, you're going to find them on a post radioactive iodine scan post-surgery, because that area wasn't even necessarily addressed by the surgeon stuff. So I think we need to realize that we need very good quality pre-thyroidectomy lymph node mapping. Also, the surgical experience, extent of thyroidectomy that's achieved. What are the radioactive iodine uptakes you're getting from your local surgeon that you use all the time, and maybe ones that you don't interact with as much? Because I've noticed significant differences in this, some where it's barely any uptake, and then others where there's substantial uptake. Prophylactic cervical lymph node dissection, is that being performed or not? Variations in the thyroglobulin antibody assay, because there can be interference, and sometimes we've had it where it seems it's negative and it's actually positive. And then also variation in thyroglobulin production by tumors. We've already noted that aggressive tumors may not be as good at secreting thyroglobulin, and there are also issues with having thyroglobulin splice variants made by the tumor, heterophile antibody interference, and also biotin can interfere potentially with some thyroglobulin assessment. Also, when looking at this, how prevalent are lymph nodes in thyroid cancer? And it is noted that up to 20 to 50% of differentiated patients with differentiated thyroid cancer have lymph node mets by pathology, but many of them are micrometastases. Pre-op ultrasound detects a good chunk, but definitely not all, of malignant lymph nodes. And we know that their worst relapse rate is associated with nodes on preoperative ultrasound versus microscopic mets discovered with prophylactic exploration. and that pre-op ultrasound can alter surgery in up to 40% of the patients, which would mean addressing lymphadenopathy. That isn't, if it isn't addressed during surgery, then needs to be found and potentially addressed later, and potentially would be picked up on radioactive iodine. A couple of studies I'd like to go on and talk about real quickly in regards to this. Anka Avram has a very well done study. It's 320 patients with differentiated thyroid cancer. They had an endocrinologist do a pre-whole body scan risk stratification, really based on histopathologic data. And they decided whether they were going to use radioactive iodine treatment, yes or no, and then what dose, low, medium, or high. And then there was a nuke med physician who was blinded and would just read the scans and such, and another who had all the clinical data. And then later, the endocrinologist was giving clinical data, including the thyroid globulin and whole body scan, to redo their recommendations in regards to radioactive iodine treatment or not. What you see on this slide is, one is the decision to treat or withhold radioactive iodine based on risk stratification, and over here will be the radioiodine dose that was given. And paying specific attention to intermediate risk, you can see there was some upstaging with the final risk stratification, and some people went even up a higher amount of high risk. And when you can see the recommendations for radioactive iodine here, when they started, most were getting a medium dose of the intermediate disease. And then later with intermediate disease, once all the data was had, there were 3 who didn't get any, some who were downgraded to low dose, and some remained in intermediate dose. Overall, what they found was there was an associated change in management in about 30% based on what was found by a radioactive iodine scan performed post-surgically, and that the endo referred 19 additional patients for radioiodine, and 3 they canceled therapy. This, while a good study, this has some limitations, I think. One, really an endocrinologist wouldn't decide on radioactive iodine just with the histopathologic data. There would be other clinical data in the thyroid globulin. So did this lead to artificial inflation of the treatment upgrade? What kind of lymph node mapping was really performed preoperatively is not delineated. And then there were 8 patients who had bulky residual lymph nodes or residual thyroid disease. And so that comes to, comes to question, was there a big variation in surgeon experience for performing the thyroidectomy? And the thyroid globulin parameters used by endocrine alone in conjunction with the whole body scan to determine the final recommendation were not really spelled out well in the article. There's another article by Agate et al. That looks at patients after they've been treated with radioactive iodine for quote ablation, although many of these were intermediate patients, and so maybe the term adjuvant therapy should have been used, but they got 30 millicuries. There were 200 that were intermediate risk. When we look here and we see whether they have thyroid remnant, there was a good chunk that had thyroid remnant alone, and then 8 identified to have lymph node mets, 1 mediastinal met, 2 lung mets. And when you look at it, total low risk and intermediate risk, 11 had metastatic lymph nodes, but 10 of 11 were noted by ultrasound and confirmed by cytology, so would have been found potentially anyway without radioactive iodine. And so in the end, only 6 or 1.1% of mets were detected by radioactive iodine whole body scanning alone. And this is just to show that thyroid globulin didn't help much. There were 3 with lung metastases, and you can see 2 had significantly elevated thyroid globulins, but so did many with just lymph nodes, and there was 1 lung that didn't have a significant elevation. I'd also like to make the point the same group did another study. The study I just told you about was with thyroid hormone withdrawal. They also did it with recombinant human TSH. And again, looking at the post-therapy scan, there was only 1.3% of the time that there was a surprise on metastatic disease and stuff that was found. So not that commonly. So I think the questions are, with looking at the scanning post-surgery, prior to radioiodine, decision for treatment and such, does early detection of cervical lymph nodes really improve survival? And so we know that we have patients with proven thyroid bed foci of cervical lymph nodes that we potentially follow at times, and they can remain stable for years. And metastases is not initially detected and potentially could be treated later. So there's no data that early use of radioactive iodine actually translates into improved survival. There is such data, I think, suggestive for thyroid surgery, but not really for radioiodine. This other article here by Castaneda makes the point, this is looking at patients who were rated low risk or intermediate or high risk by ATA or ETA criteria, were followed for 8 to 12 months, and then they were restaged with their delayed risk stratification, and many of these acted as low risk. And so begs the question, if many of these are going to be low risk and behave, we're not going to see a benefit with treating them with radioiodine, so ergo, scanning with them radioiodine may not be helpful. So I would suggest an individual approach in intermediate risk patients for iodine imaging. And looking at patients with aggressive tumor histology, or of course now that we are in the molecular error where we can test for molecular markers, to use that to help determine whether we should be doing scanning or not. AJC stage 3 or higher. I think probably not the presence of microscopic extrathyroidal extension unless there's mutations present. Operative lymph node size is somewhat bigger. Maybe we can decide on a thyroglobulin cutoff. And also if there's question of lung nodules or lung disease, of course, I think we need to think about using radioiodine. So in the end results, I think the staging tool, if we're going to use radioiodine imaging, needs to accurately select patients who will benefit from the intervention and the test results that we're trying to guide. Now pivoting over to treatment, here we have a radioiodine pill and radioiodine scanning. This is just a tongue-in-cheek thing that I joke with my nuclear medicine docs, that we can spin the wheel and decide on what dose we're going to give for radioiodine. And of course we do that more thoughtfully, but sometimes I feel like we could spin a wheel within a certain thing and come up with a dose and go with that. This is a slide that I borrowed from Mike Tuttle, so thank you, Mike. And I think the point makes out, and we do this with our Martinique group, is there are 3 main reasons for using radioiodine. There's residual normal ablation, there's treatment where we know there's disease, and there's adjuvant therapy, where we have the desire to destroy residual small volume cancer in an attempt to decrease recurrence and improve survival. And again, I think these are the patients where we have some heterogeneity in what the patients are like, and heterogeneity in seeing benefit in various articles. So adjuvant therapy is really therapy for thyroid cancer, referring to radioactive iodine following thyroidectomy to help decrease the risk of recurrent cancer recurrence. And it's not really ablation where you're just getting rid of normal tissue to make follow-up potentially easier. I think everyone's familiar in this audience with estimable and high-low, and this is really more low-risk patients. But I would like to point out that in the high-low study, there were patients with T3 disease and N1 disease, and that they did well. And you can see here, and it was mentioned yesterday, 85 to 90%, at least high to mid 80% of success of being ablated and having no evidence of disease by diagnostic scan and thyroglobulin testing. So we do know that we can be successful in some of these lower risk, maybe intermediate stage, or at least it suggests that we could be successful in treating them with low dose radioiodine. So recommendation 56 from the American Thyroid Association is interesting in the context of 5 to 6 years later, when radioiodine is intended for initial adjuvant therapy to treat suspected microscopic residual disease. Administered activities above those used for remnant ablation up to 150 are generally recommended. And of course, we can consider higher doses, particularly if there's more concerning structural disease or lymphadenopathy. I think there are a couple of articles to look at this in regards to dosing and such. Looking at Castaneda, another article where there were 225 intermediate differentiated thyroid cancer patients, and low dose with 30 to 50 millicuries or high dose with 100 millicuries was used for treatment. And basically you can see all patients, T1, 2, N1, and T3, N0X, and T3, N1, and there really wasn't any significant change in benefit. And so the conclusion was high-dose radioiodine really did not improve survival in this group of patients with intermediate disease, with the patients they had in this project. There's also Khrushchev et al., 970 PTC patients, anywhere from a T1 to T3 tumor, retrospective 60-month follow-up. They were status post-thyroidectomy, and they either got low or high dose radioiodine based on a cutoff of 75 millicuries of radioactive iodine, and then they look for rate of structural recurrence. You can see estimates for T1, T2, and T3 tumors and the disease-free survival, and you can see the p-scores are no different, and so really do not have any significant difference in this group, again, looking at intermediate disease patients. And then there's Sabra et al., one of Dr. Tuttle and Fagan's colleagues, and this is a study looking at 181 PTC patients with N1B disease that had lateral lymph nodes disease, total thyroidectomy, neck dissection, radioiodine remnant ablation. They looked for best response to radioiodine activity administered. Here we see they got either a low, intermediate, or high activity as listed. And you can see they looked at stage 1 and stage 4A. And you can see that patients with the low stage 1 is the darker bars. There was no real association with the treatment and decreasing structural persistence, while with stage 4A, there definitely seemed to be a trend towards reduction in structural or better structural persistent, or less, I'm sorry, I'm messing this up, less structural persistent disease after radioiodine. So the summary of this was there's no correlation between radioiodine activity and best clinical response. Greater than 100 millicuries is adjuvant therapy in N1B disease is unlikely to improve initial response, especially in younger stage 1 patients. Radioiodine, higher doses, 150 to 200, may improve response in older patients with stage 4A, who are probably at highest risk of poor outcomes. And then potential radioiodine benefits should be balanced against adverse effects. Of course, we've talked about this: dry mouth, dry eyes, maybe transient impairment in gonadal function, and also risk for secondary neoplasm, as there's some debate on that, particularly with rising doses of radioiodine. So all things to consider taking care of the whole patient. There's another 2 articles which I think are worth referring to in this. One is intermediate differentiated thyroid cancer and lack of radioiodine effect on outcomes. Here's Podnos et al., and they basically didn't find a difference in outcomes using radioactive iodine or not in several thousand patients, except potentially positive effect in patients older than 45, tumor greater than 2 centimeters with clinical lymph node disease. And so I think there's subsets of patients with intermediate disease that will benefit from radioiodine. Interestingly, and this I think Dr. Gulick mentioned this study by Mayo Clinic, where there was a change from using unilateral to bilateral thyroidectomy or near total thyroidectomy. And we see that rate went up, but then, and as did the rate for use of radioiodine. But interestingly, the 10-year cause-specific mortality and recurrence has not improved despite much more prevalent use of radioiodine in patients that have undergone total thyroidectomy. And then Rule et al. Is a very nice study done and looking at a large database and intermediate differentiated thyroid cancer patients. And this actually did find that there's a potential benefit, which you can see there are T-scores, P-scores, I'm sorry, that indicate significance, and basically overall survival difference with intermediate risk thyroid cancer patients with a benefit with radioactive iodine was noted, and even including patients under 45 years of age. So a little bit of difference of finding. I think the other thing to note is, and we've alluded to this, that there's the long-term response and how patients do, and intermediate risk. Again, you can have somebody with intermediate risk, but if they have an excellent response, their recurrence rate drops from the 30 to 40% down to 1 to 2%. And so I think we need to think about this. If patients are going to do well with intermediate risk, maybe we need to wait a little bit till we do the radioiodine. So where are we going? Transitioning from individualized to individualized management. Classically, we did total thyroidectomy. Many people got ablation or adjuvant therapy and got suppression of their TSH and very aggressive follow-up, to now more a risk-adapted management treatment plan tailored to the individual, and follow-up treatment, follow-up individually tailored as well. And I think Marcus made that point that we need to tailor things to our approach. So to wrap up here, principle number 6 from our Martinique group, optimal administered activity for adjuvant treatment really cannot be determined, as what we said, from the literature we have right now. Until definitive data are available, selection of the optimal administered activity for adjuvant treatment should be based on multidisciplinary management recommendations. And what am I recommending as far as management of intermediate risk PTC? Well, leaning towards a total thyroidectomy. We can debate about the need for a prophylactic neck dissection if a good preoperative lymph node mapping is done. Evaluation of a postoperative TG, and consideration potentially, if you're debating, we do a neck ultrasound at 3 months and look at our TG and see how well we've done. And then consider diagnostic iodine whole body scanning in a subset of patients. And then potentially for remnant ablation, we use 30 millicuries in adjuvant therapy, 50 to 150, probably usually 100 to 150 would be our bias. TSH suppression, and then of course, reevaluation. And if patients are having an excellent response, then we can make a little bit increased intervals between our follow-up, while if they have biochemical or structural incomplete or indeterminate response, additional evaluation and more intense monitoring. And I'm going to finish up. Basically, this is another slide I borrowed from Mike, but I think it makes an important point, and I'll just summarize. But some patients are at a high risk of having events. They're going to benefit from radioactive iodine. They may hold a maximalist mentality for treatment, and then maybe the treatment that they've gotten, the surgeon wasn't as experienced, there isn't as much experience with the preoperative ultrasound imaging and such, and they may benefit from radioiodine. And then there are patients who are at low risk of events, not likely to benefit from radioiodine or don't have radioiodine avid disease. They may have a minimalist mentality, and they've had a terrific surgeon. You know, our surgeons, sometimes I end up with undetectable TG postoperatively, and postoperative ultrasound reveals no disease. And I'm not sure those intermediate patients are going to benefit from adjuvant therapy. And I think there's more research and stuff that we need to do, low dose versus a high dose. And what do we do with that? We need to make sure we have apples to apples. Some of the studies have really mixed up ablation and adjuvant therapy, or some adjuvant and treatment, and they really need to be divided out as we've recommended by the Martinique group. And again, well-controlled prospective studies. We need multi-center, multi-country would be wonderful. And this is us in Martinique, and you can see several of us here. We got Ben here, and myself, and Cesar, and Doug, and oh, there's Mike. Mike's hiding in the back, so trying to be inconspicuous. So I thank you for your time, and again, I apologize with the goof up in the beginning with the slides, and everyone, and enjoy the rest of the day.